Is this thing on? Welcome back, guys, to another episode of the Summits Podcast. Thank you for joining us today from wherever you get your podcasts, or if you're checking us out, on the Heroes Foundation YouTube channel. Thank you. If you're on the YouTube channel and you haven't subscribed, please do so. Hit that subscribe button and also hit that little notification bell so you can be alerted when new episodes like this one drop. Today's guest is Dr. Steve Angus. Welcome to the Summits Podcast.
Thank you so much. Thanks for having me.
Absolutely.
I do want me to give a quick history. So I'm in Indiana now at the IU School of Medicine in the Department of Pediatrics. I do cancer research as a basic scientist. Prior to that, I was at UNC Chapel Hill, and also prior to that, I worked at Duke University. And backtracking, I started off getting my PhD at University of Cincinnati. So did a complete circled back to the Midwest, but all in that way, I've always been interested in doing cancer research. And my last move before coming to Indiana at the University of North Carolina in Chapel Hill, we started collaborating with Wade Clapp. He's the chair of the Pediatrics department at IU School of Medicine and really involved in Riley. And so we can get more into it in a moment, but my research kind of, that connection really drew me to potentially being interested in coming up here. And I've been excited. It's been great. I've been up here since August of 2019.
Nice. Well, most Hoosiers would have picked out, and as they heard UNC and Duke. Yeah, and typically,
not happy with me.
I'm at IU and Purdue,
exactly.
Or switched over. Yeah. So if you had to I'm gonna put you on the spot here. If you had to show your allegiance to one or the other, which
one of the Carolina schools? I can't believe you said Carolina. Duke for sure, but it goes back to my childhood and being just the Duke teams in the back-to-back championships. But I will wear some IU stuff. I'm repping IU. So.
All right. Where were the early years at? Where did you grow up at as a kid?
Oh yeah, I grew up in Fairfield, Ohio, which kind of for if folks don't kind of the 275 belt around Cincinnati. It's a little bit north of that, kind of like where we are in relation to 465. So kind of around Cincinnati. I tell people Cincinnati, but if you really zoom in on a map, nowhere near downtown.
Okay.
That's where I grew up. And
it's kind of like when people ask where we're at. I'm like, Indianapolis. They're out of the state. They're like,
and then I'm from. Yeah.
They're like, okay, well, we can get a little more specific now.
You can give more specifics.
Yeah.
Which high school in Cincy did you go to?
I went to Fairfield High School.
Fairfield High School.
Mm-hmm.
Okay. I know a few people from Cincy, and I don't think they're not from Fairfield. They usually.
My wife's grandparents are from Mason, Ohio.
Yep.
So home of Kings Island.
Yeah.
So
now, what did you do undergrad?
I did my undergrad at Miami University in Oxford, Ohio. So I stayed close to home.
All right.
My dad was a professor there at the branch campuses. There's the main Oxford campus, and then Hamilton and Middletown have branch campuses. So neither of my parents were in science at all. My dad was in computers and math and got his PhD from Ohio State. And then my mom was a teacher for a long time. And so I was really kind of the first in the family to kind of head toward biology and research or anything like that.
Was it Ohio State or the Ohio State?
I would say the Ohio State.
Okay.
Yeah, did I? Yeah.
I just want to make sure.
For my dad and for all the Buckeyes out
Didn't they trademarked that or copyright or something crazy?
Yeah, made a big deal about that. But
big fuss about it. Yeah.
Well, cool. So at what point then did you, you kind of touched on it. At what point, though, did pediatric oncology really kind of take your focus?
It was, so I was at university, the last stage before coming up here, it was in North Carolina, and my mentor there, Gary Johnson, had developed a way, and I'll speak really broadly, we can get into more specifics, but of looking at the use of kinase inhibitors. So it's basically just a drug used to treat many diseases, but predominantly cancer. And the focus of his lab, we were working on breast cancer and melanoma. And really, there are over 70 kinase inhibitors. It's just a class of drugs. You can think of it like that. They've been really effective in many settings. 70 of us, you kind of see, if you look at the trend over time, the first one in 2001, and now there's over 70. So in just 20 years, a number of them. And he had a methodology to kind of look at what happens to cancer cells when you use those, because they can become resistant. Like the tumor could respond for a while, and then they could develop resistance. So just really understanding when and where to use those best, and in the context of breast cancer and melanoma. And he published a pretty big paper that gained a lot of attention in the field, and he got in contact. Actually, Wade Clapp got in contact with Gary. Because Wade works on a couple of genetic diseases, neurofibromatosis type 1 and 2, and with NF1, that is where their number one cause of death for patients with NF1 are these malignant sarcomas, and they occur. All of the clinical manifestations pop up fairly early, so they're seen in pediatrics and pediatric young adult. And really, as I thought about my future and what I wanted to work on, there were several times, it sounds hokey, but I honestly would like walk past the Children's Hospital at Duke and just think like, oh, just what and I was happy. I had my first kid while we were down there in early, 2003, or actually, no, 2006, 2004 to 2006, playing the wrong years. And just knowing that there were so few prospects for effective treatments in that realm, we were kind of studying some areas where it had been successful, and maybe cancers that were really well funded. There's a lot of research going on, and so I just became interested in these, more rare diseases, in particular these rare pediatric cancers, and maybe seeing an impact and seeing it kind of translate. And when I use that term, maybe you guys know, just meaning stuff we do in a lab, like how quickly can that affect treatment for patients, getting clinical trials, and maybe and through collaborations with Wade that I started when I was in Gary Johnson's lab at UNC, we were able to kind of see the beginnings of that, and it was really exciting for me. So
nice, yeah. I just have to bet it's very fulfilling to see things from the side that you're on, trying to find options and in routes into impact down the road, right?
Absolutely. I think I was attracted to science because at the end of the day, we are really puzzle solving, and you have to be kind of fascinated and curious, and all the molecules and the interactions. But when you can work on those at the same time as kind of maybe advancing and seeing something before in the clinic, it is really, really gratifying, really motivating too.
Yeah. When you talked about how these, I guess the cancer cells can become drug resistant at some point. In general, how often does that happen, and what length of time? I'm sure it's probably all over the board, but that's for somebody like myself who doesn't have the most patients in the world. That's got to be extremely frustrating when that happens. Yeah, for a lot of reasons.
That's a great question. So it can differ depending on which drug you're talking about, in which patient, how long it's the durability of a given treatment. So I will say an example I give a lot since I was working on melanoma is there's a fraction of malignant melanoma, this kind of skin cancer that's really aggressive and outcomes are really poor. And a kinase inhibitor for melanoma, the first one was approved in like 2011, 2012, and now there are a few more. Those had an amazing effect. I can envision this picture that was published of a person with tumors kind of popping up all over their trunk. And I'm going to say, but within 3 or 4 months of being on that drug, it completely all, melted away. The tumors had regressed, and the patient looked pretty normal. And then another, I'll say 4 months later, roughly, all the tumors were back. So for something like melanoma, where it's so aggressive and the survival is so poor, those drugs were still approved despite that challenge of them, kind of becoming resistant. And as that was happening, a lot of research went into how is that happening, and can we use a second kinase inhibitor? And in that example, I just gave you, actually now the standard of care for patients with this specific kind of melanoma get 2 kinase inhibitors, so 2 different drugs at the same time, and that's more durable, lasts longer. It can vary by patient, but I'll say roughly, now you may be talking about, a year or more, but still maybe 2 years down the road, you might get resistance in that case. And so the timelines can vary, but almost always, cancer cells are so resilient, and they kind of adapt to these drugs after you as a patient start taking them. It's kind of an ongoing, challenge for us, really.
Yeah. So would you say the bulk of your studies now are just continuing to try to improve that, to extend that time, or to figure out a way to make a medication that doesn't become drug resistant? I mean, if that's even possible.
Yeah, and I think really that example I gave in melanoma was kind of like, here's a really good drug, and the drug was approved and used because it actually targeted, the melanomas have a mutation in a kinase. So it's a very clear case of, we should target that kinase with a drug. Some other cancers don't have a clear target to go after, but in this case there was one, and then it was targeted, had a great effect, and then, now we may need a combination therapy. And so that's kind of the mindset, I think, of everybody in the field. Is it's likely if we give just a single drug, it's likely that we're going to encounter this, and so we can start looking for that, expecting that in the lab, and almost invariably we'll see it eventually in patients. And the hope is we've kind of got some prior knowledge of ideas of a combination that might work. So for something like pediatric tumors where maybe nothing is approved, it's just kind of conventional chemotherapy and radiation. Our hope is, let's first just find like drug number one, and then at the same time, so already back here, let's just find a good drug number one, but already thinking about, before that even comes close to a clinical trial, what's going to happen, how might they become resistant, is there a drug too that makes sense?
Right. Oh, and also lower the toxicity at the same time.
Yeah.
No big deal though.
It is. Yeah. That is a definitely a challenge, and the balance of that. And then I mentioned, before we started recording, that some of the drugs we're interested in, there are 70 kinase inhibitors, and many of them approved for adult cancers. So it's a big change. When you think about then the dosing for pediatric patients, it's kind of a whole other challenge, whole thing to think through. And as you said, all these drugs have an effect. It's something, many of them, most of them are a pill you're taking. So you want to kill the cancer cells or the tumor cells, but have a minimal effect on quality of life. So.
Right. When they have a drug that, say, is approved for the adult population, and you're looking at it for peds, is it really just the dosing piece? But I'm oversimplifying, I'm sure, or there are other factors to consider as well.
Yeah, it could be the frequency. Yeah, how how quickly the drug gets metabolized, that could come into consideration. So a lot of times it's just, a smaller person, just by sheer body weight.
Right.
So we'll use and I should say I'm a basic scientist, so this is getting into the realm of clinical pharmacology, but broadly speaking, and maybe less frequent, although many times you usually want to kind of lower the amount, say in milligrams of the drug you're taking in pill form, but still take it consistently to really suppress the growth of those cancer cells that you think, if you've gotten all the way to the point where you're thinking this is a good drug to use, you kind of want to keep it as much as possible. But there are considerations like a drug holiday, maybe if that's having a good effect, but we just need to, the patient needs to take a break for a little bit.
Yeah.
So
do you have to consider, I assume, obviously in children, you have to consider what long-term side effects might be of certain ones, as far as like growth and developmental and things like that.
Yeah.
I assume that goes along with dosing and picking and everything.
Yeah, I mentioned this genetic disorder called neurofibromatosis type 1, where the leading cause of death is eventually development of these malignant tumors. Patients, the hallmark of this disease are these benign tumors actually that can form. They can actually form on the skin. They're neurofibromas, or under the skin, and they really affect quality of life. It's just a huge burden for the patients. And so through collaborative work with Wade Clapp, we've kind of advanced a couple inhibitors to prospective use. And the first one, a MEK, is a kinase, or it's like there are two kinases, MEK1 and MEK2, but MEK inhibitors got approved for these benign tumors for NF1 patients in just a couple years ago, in 2020. And so it's exactly what you're bringing up is this consideration. Okay, now you're giving this drug to maybe a child that's 4, 5, 6. They're doing trials now of younger patients, and then thinking maybe this helps shrink these benign tumors and improve their quality of life. But now, okay, how is this going to work? Or be on this kinase inhibitor, be on this drug, for the rest of your life, or is there a window of time where it's most effective? So that's a great question, and something that people on the clinical side designing trials are kind of following up on.
Yeah. Two-part question for you. One is what are you looking at now? Like what is the hot item on the lab bench today? And then secondly, if you would kind of describe some of the Team Joey funding that we provided through some products of yours, if you would kind of describe what those products are and how things are going there.
Yeah, so
It might be the same answer for all I know.
Yeah, and actually, it all does tie together. So I think the biggest tie is the work that I started doing with my mentor at UNC, Gary Johnson, and I'll go a little bit more, and you can ask follow-up questions. But so I mentioned kinase inhibitors. So kinases are a class of proteins. A lot of them in BRAF melanoma, BRAF mutant melanoma. It's like, okay, we should have BRAF as a kinase. Oh, so we should have a drug that hits BRAF. In other tumor types, it's not so clear. You might develop a certain type of solid tumor where there's not one of these kinases that's responsible for really driving the cancer. So the technique that I learned and that Gary was developing was to look at all of the kinases in a cell, and there are hundreds, over 500, and if you include, comprehensively, like maybe even over 600 to 700. So how do you study all of those at once unless you set up hundreds and hundreds of experiments? So the technique that we use, and with generous funding from the Heroes Foundation, we're applying this to pediatric sarcoma models. We can take a sample and actually look at which kinases are most active. So maybe a tumor where, from a genetic point of view, there's not a mutation in a kinase that makes it very clear that, we should target that one, but there's something else going on, and we know that the cancer cell is kind of quote unquote messed up compared to a normal cell. It's signaling the way it transmits signals, and kinases are deeply embedded in that. Which ones might be the most active? Which ones should we think about targeting? Okay. And so this technique that's really been supported, we can kind of apply this where we've never applied it before to these kind of understudied pediatric sarcomas, and we're doing that. And a related component is a lot of these drugs. I mentioned there's a BRAF inhibitor. As it turns out, I just said kinases, and I said there are hundreds of them. They're all kinases because they have a similar structure. And so a lot of the drugs that are used, because of that similarity, it'll hit the kinase you want to hit, but it'll also hit, and when I say hit, like inhibit or block the activity of a bunch of other kinases. And so that can cause what you mentioned. It can cause toxicities because maybe you take a pill, and these other kinases might be important for other normal cell processes, and they typically are. So that can be a detriment, or that could be kind of the reason it's doing so well, because maybe you're inhibiting a few kinases that otherwise would drive resistance. And so we can use the same technique. Again, I'll get into more or less detail if you want, but this approach that we take of studying the kinome, all the kinases kind of comprehensively, to take drugs and see which kinases are being hit by a given drug. Okay. And that's sometimes, so I'll give, that's a great example. I'll just keep using that one. A BRAF inhibitor, if you actually put it on cells and do this assay that we can do in the lab, we see BRAF getting inhibited, this kinase, but 40, 50 other kinases in the cells to a pretty substantial extent. And so in some cases where I talked about using a drug that's approved for one cancer in the realm of pediatrics, is we will just screen a bunch of compounds that are approved, find that it works really well, and doing this assay that we can do in the lab, we can see which kinases it's actually inhibiting. An example, I'll say a name, don't worry about the specific, crizotinib is approved because it's an ALK inhibitor. ALK is just an acronym for another kinase that's involved in some other cancer types. And so that drug was used, and it was discovered that, it hits ALK, but it also hits this kinase called FAK. Focal adhesion kinase is the acronym, and actually that FAK is a pretty important kinase, and so we're now interested in following up on that, using more specific inhibitors for FAK. So
it's maybe a dumb question, but I skipped this day at med school. When you say inhibits, does the cell? It's still there. It's just not having a negative. So do you have to then pair it up with something that wants to then destroy the cell?
Well, that's
how my brain's thinking. But
no, that's a great question. I mean, that's a fantastic question, and one I should have mentioned. So these drugs actually bind. You can think of it almost like a Pac-Man. This place where a kinase will bind ATP. So ATP, kind of the energy unit of cells that we all need. Kinases use ATP. And so the drugs are often designed where ATP binds to the kinase. This drug binds instead. In many cases, these drugs are used. So the drug actually binds there and occupies that site, and it doesn't necessarily get rid of that kinase. It just blocks its activity. Its function then is to use ATP to transfer to modify other targets. The kinase will kind of, like flipping switches. Like this kinase is on, it's now kind of going around, turning on, affecting other proteins in a cell and kind of affecting signaling in that way. So we do think about that. There are drugs now that where one part of it binds to the kinase in the way I just described, like ATP, and then coupled to it is something that brings in degradation machinery that actually gets rid of, the actual protein, gets the protein to turn over.
Yeah,
so that's another realm that we're really interested, kind of even broadly, like folks are really interested in. Maybe it'll be even better if we got rid of that mutant kinase, or that kinase driving the cancer entirely.
Yeah. What brought that to my memory was, I remember several years ago, we were down at Riley and looking at, it escapes me what not only the cell type was, but also what the drug was. But literally, sped up on screen, it showed, this agent attacking the cancer cells, and literally you could see the cell like essentially blow up.
Yep.
I don't know what that just happened, but that was freaking cool.
Yeah.
Let's keep doing more of that.
Yeah, we've got students doing summer internships now, and that's when I talked about the combinations we're looking for. Sometimes a drug might be effective, but it just kind of stops the cells from dividing. Stops the process of one cell becoming two cells, which is kind of a foundational problem in tumors growing out of control, and the rate at which they do that can vary. But if they're still there, I talked about like reduced, I talked about that example where patients could just have a large tumor and you want to shrink the volume of it. What we'd really like to see is those cancer cells dying.
Right.
And so, so that's one of the things we think about. Let's maybe find one inhibitor to slow down or stop their growth, and then another combination, another drug that can really, maybe it's a second drug where you're really trying to hit the cancer cell. Maybe it's where you're really trying to, get the body's immune system to now, recognize and eliminate those cancer cells that are kind of halted. So a lot of ways to go about that, but yeah, that's the goal is, think about a successful surgery, or like a melanoma. If you catch it before it spreads, you just have surgery and it's totally gone. The whole thing is out. I mean, that's what, and so we're talking about taking a pill to stop the cells from growing. What we really want is eradicate, get rid of everything. And so yeah, that's something we think about.
If you could have that done by the end of the year, that'd be great.
Yeah, we are. Yeah, that is the goal. And I will I'll take that under advisement.
Sure, thanks.
Add that to my list.
Right. Very PC answer.
Yeah, exactly. Yeah.
Well, September is Multiple Cancers Awareness Month, but two in particular, leukemia and lymphoma. So you could say it's Blood Cancer Awareness Month in theory. So Dr. Angus, what's your cancer story?
That is a great question. My cancer story, I did not, I wasn't born with a syndrome like NF1 or NF2. I did all my training. I was working at Duke and then working at UNC, where I started working on kinase inhibitors. And I gave this example earlier that the first, when I talk about the molecules, the drugs that we use, the first one was approved in 2001, and it is kind of the poster child. It's Gleevec, or the generic name is imatinib, and it was used to treat a specific type of leukemia called chronic myeloid leukemia. And without getting deep into the details, it's the driver, the thing that really caused that leukemia to blossom and grow out, these cells to grow out of control, is kind of a messed up kinase. And so there's an amazing history, kind of just understanding that disease at a genetic level, all the way to getting to the cell molecular studies of that, getting all the way to like thinking about drugs and using kinase inhibitors, and that's people have been trying to do that for a while. So I was at UNC working on this, applying this methodology I mentioned to kind of track which kinases were doing what, which drugs might work, how they become resistant in breast cancer and melanoma. And in 2017, in like fall of 2017, or is it 2016? I may have the year wrong. This is, I remember I was, during the summer, I was living in North Carolina. It's extremely hot. And I just remember noting that I kept waking up in the middle of the night and I would have just like huge red patches on my elbows. You think like, oh, at night you're like your elbow's bent, maybe you're just kind of getting really hot and sweating. And we had air conditioning. So like more so than I'd ever noticed before. I'm like, well, this is kind of odd. I didn't think much about it. It just so happened at the same time I was having some blood tests to kind of, checkups at my age to kind of track cholesterol and everything. And my primary care doctor noted that a specific type of cell called basophils, so you get your complete blood count, or CBC. She's like, oh, this population of cells is really high if you've traveled out of the country. It's like, sometimes this is, your body's response, maybe an infection or something. I thought, no. I really haven't. And she's like, well, let's do a follow-up, in a couple weeks, and let's keep an eye on that. So she did a follow-up. Those cells were still high, and it's of your white blood cells. I wasn't thinking cancer or anything at the time. I just thought, well, that's kind of odd. It's kind of weird, but she's got it under control. She made me an appointment with a hematologist, to look at my blood more carefully at UNC. Made this appointment, and I remember I was in the lab, and I got a phone call. And I answered my cell phone in the lab, I was standing there, and they said, oh, you were going to see Dr. So-and-so in hematology. Actually, we've reviewed this, and we think you need to see this other doctor, and who's a hematologist oncologist.
You're like,
the old hem-onc.
Yeah. Okay.
Yeah, and then, and kind of the realization set in, oh, they think this is cancer. Yikes. Okay, so I remember calling my wife, and I was like, they recommended to see a different doctor. So I went for the appointment within, a week or so, and I walked in, and I sat down, and they were drawing my blood, and across the table I could see they have all the vials, they kind of cap them, and they're collecting 6 or something for all the different tests they're going to run. And one of them rolled over, and I just looked, and it said BCR or ABL on it. And so ABL is a kinase, and this basically this genetic alteration makes this fusion between 2 genes, BCR and ABL, that's a driver of chronic myeloid leukemia. And I was like, oh, I was like, I bet that's
so did you
what
tell
I have.
them that you knew that?
I didn't actually. I don't think I told the phlebotomist. She was kind of gathering them. I just think it was all an internal conversation. And
kind of a shit moment.
Yeah. I was like, oh, I bet that's what that is. That's what they think it is.
Yeah.
They're testing for this. Now, I did think, and I just written with my boss, we just written a review kind of on the, the history of kinase inhibitors, and you always, you use Gleevec or imatinib, this drug approved in 2001 to treat CML that treat in 2001, and patients are still on it, and this is now, almost 2020, 2017, 2018. I thought, kind of took a breath, and it was good, I think, that I had the knowledge I had, because I thought, there are approved drugs for this. Right. And we talked about resistance. So that first one got approved. Now there are many more. Yeah. There's 3 or 4 more for this same type of cancer, in case you became resistant to imatinib or didn't respond to it. I will say, so that's my cancer story. So that was while I was doing my studies on kinase inhibitors, I began taking a kinase inhibitor. And so now I've been on it for several years. The good news is my cancer responded almost immediately. So I started on imatinib, so the first approved drug. A couple reasons. There's more long-term data. You talked about side effects. All of them will cause fatigue, and there's a chance of, here are the potential things that could happen. It's pretty scary to see all this list. So they kind of checked my heart after I've been on it for a while. But the most important was they saw, the cancer cells go down to undetectable levels within weeks, within months. Yeah. And so the key is staying on that. And now there's the potential that I could try coming off of the drug and seeing if the cancer comes back. There have been clinical trials where they've tested this with this type of leukemia I have, where about half the time it doesn't come back, and the patients are able to stop taking the drug.
Interesting.
And sometimes it does come back, but in almost all those cases, they could just resume taking the drug, and it goes back down.
So it doesn't rebound. Next question I was going to ask is, if it does come back, does it come back the same, or does it come back even stronger?
Yeah, it's so far that I'd have to review the data again, but the initial studies it was still responsive to that drug. So, and I will share, a couple of things about that. Number one, I don't want to minimize it, but I did think, I had several thoughts at once. It's a very treatable cancer. And so it makes me hopeful about the things we're trying to find for cancers that have a much more dire outcome. Can we get to that, and with tumors that are solid and not kind of in your blood, there are inherent challenges with that. But can we improve these, the way that was improved for me? I'll also acknowledge, maybe just being a scientist and maybe just my personality, I kind of absorbed it and like took a deep breath and like, okay, this is going to be okay. I think kind of my faith undergirded me a bit, but I thought also like this drug has been around for almost 20 years. It's very safe. There's a lot of data about it. And if I don't respond to this one, there are a couple other options. Yeah. But when I told my wife and kids, I think, you just hear cancer and it's a scary word. I was trying to reassure them, but I don't want to minimize it for them. It was kind of, and it definitely changed me. I mean, the side effects, I don't want to sound like I'm complaining about it, but the fatigue, things that happen when you take this drug every day, affect your life. Mm-hmm. And so I think that was my kids at the time, and this was now 5-6 years ago. So they were middle school. And so I said, I'm not undergoing like chemotherapy.
You need to get out. You mean the kids?
Oh.
Get out and cut the lawn.
Yeah.
I'm a little tired.
I used it to. Yeah.
Some strategy there.
There may have been some extra kindness there for a bit, but no, they've been super supportive. And again, I'll just circle back to I think the biggest motivating thing for me is now like, this is there's been such success. Like the cancer that I have with these drugs, like can we get there with some others? And so I think, and I, circling back, it may be a kinase inhibitor plus some other drug that's not a kinase inhibitor. It's likely that for some of these more complicated cancers, they maybe grow faster, they grow in different places. It's hard to get the drug there.
Would you say that your personal experience has added to the already existing passion that you had for wanting to fight this disease?
100%. Yeah, 100%. Without a doubt, and especially as I started getting. And the cool thing about starting to work with Wade Clapp at IU, my department chair and collaborator, he gets a lot of funding for neurofibromatosis types 1 and 2. There are the private foundation called the Children's Tumor Foundation, which people can look up and check out, and patients and their families. And there's a lot of, as with the American Cancer Society, there's a lot of advocacy, like your story. So when you meet people that are kind of going through this, especially when you meet parents or you meet the kids themselves, young adults, it's extremely motivating. And so I hope it can kind of push something forward. And I think. And more recently, I mentioned the MEK inhibitor in work that we did with Wade Clapp and others at a lot of institutions. There's another drug, a clinical trial was just completed, a different kinase inhibitor for the benign tumors that NF1 patients get. And so now we're on that. We're really interested, as I mentioned, they're really at risk of those tumors, those benign tumors actually transform into malignant tumors.
I was just going to ask, so, someone might say, well, if it's benign, why worry about it?
Yeah, that's one of our primary interests. There's a high morbidity, which just means it so affects their quality of life. It's really devastating. The actual physical burden of having these really large tumors, and the psychological burden, but they can affect other structures. They can cause a lot of pain. And then if you think about cancer, which is when they kind of transform and become malignant, that's what they're really at high risk for. And so we can maybe, as we were talking about before, maybe you need to start on a drug sooner so you prevent that from ever happening, rather than try and play catch up and wait until it happens. So
so we're gonna put you on the spot for a minute. Mm-hmm. Crystal balls are very
short supply right now.
Yes.
Yeah.
If you ask anybody about the economy, what do they foresee over the next 5 years? It's like, get my magic 8 ball out. Yeah, try that. I don't know.
Hoping my kids get scholarships. Yeah.
Right. Yeah. That'd be nice. What is your, let's say, 5-ish year crystal ball look like for cancer research in general, or more specifically to the areas that you guys got focus on?
Okay. Yeah. 5 years from now, I think a couple of things are involved. So the way we approach this problem sometimes identifies kinases for which there is not a drug. So I anticipate, and I'm not really in the medicinal chemistry or kind of drug development, but we have collaborators who are, and kind of in folks that are working on that. So I think the more drugs that we can have for some kinases, actually, we didn't understand this one well, but it turns out to be really important in this pediatric cancer, and like maybe driving resistance, or maybe we should just try a drug for it, at the forefront at the outset. So I think that's going to continue to increase more availability of compounds that we could give to patients, and at the very least that we could test in the lab. And on the other end, for really effect on patient care, I think we're going to get more approvals. I think, and it's not just everybody in the field, I think, is interested in, when a drug gets approved. I maybe mentioned this before, but it means pass a lot of safety hurdles. Now the last question is it effective or not? And so, for a patient with a tumor that's, you've kind of reached the end of your rope treatment option wise, having these available trials of like, hey, would you be interested in this? And, I just think as a parent for my kid, I think if you were, nothing else, say that we know people have taken this pill and it's safe, let's just see if it can do anything. I think we should continue, and I hope we push some of those forward with, the work that we're doing with collaborators at IU. And I think the combinations will be the key. And I talked a lot about kinase inhibitors, this class of drugs, but I think we now have drugs that or ways to kind of stimulate your body's own immune system to recognize and destroy the cancer cells. So I think using those in the right combination, I just mentioned kinase inhibitor plus maybe another kinase inhibitor, but a lot of times when we do studies in an animal model, we can kind of get a picture before we ever go into patients. We can get a picture of kind of as a whole organism is taking this kinase inhibitor, what's happening, and getting back again, like, is it tolerable? The toxicity is too much to bear for this animal model. And then what's happening in the tumor to the cancer cells and also everything that surrounds them. Do immune cells, suddenly go into the tumor? That could be a good thing if we can then maybe use a combination where we, further stimulate the immune system to respond. So I think that, I think those are two major advances I hope to see in the next 5 years, really seeing some things move forward.
Yeah.
Awesome.
Yeah.
Last question.
Yeah.
UNC and IU are slated to play each other this fall or this winter again in basketball. I don't recall if the game's going to be in Bloomington or Chapel Hill.
Okay.
It's out there. I just don't remember which. Are you wearing red or are you wearing powder blue or Carolina blue?
Well, since I already admitted I have a little more biased lean towards Duke versus Carolina, I don't think I own anything Carolina blue.
Okay.
So I will probably pull on
it
my IU sweatshirt. And my daughter is going to be a senior this year.
Okay.
And so she's looking at colleges, and so like if she makes some decision, by just depending on when that game is, she does early decision is like, I'm going to IU, and then I'm, extra reason to kind of support that. But,
well, one of my daughters will be a freshman at IU this coming fall, so if you need some brainwashing, I'm happy to help.
Some extra swag, some extra gear.
Right, yeah.
Yep.
Cool. Well, hey, Dr. Angus, thank you for your time. We appreciate you sharing your story with us, and thanks for all the work that you do on behalf of
thank you. Thanks to the
everyone
Heroes Foundation. Yeah, the support has been fantastic. It's really catalyzed our work, and we so appreciate it.
Well, thank you. We're happy to do it, and we're happy to do more.
Thanks so much. It's great to be here.
And all you guys out there listening, thanks for tuning in on this episode of the Summits Podcast. Again, if you're on the Heroes Foundation YouTube channel, hit that little subscribe button, little notification bell, so you can be alerted when this episode and the next ones out in the future drop. Thanks again for joining us, and beat cancer.